Hi, everyone. Thank you for joining us today for the first webinar in the Dravet Syndrome Foundation's Listen and Learn educational series for professionals. We'd like to thank our educational sponsors who made this series possible, including Greenwich Biosciences, Neurelis, Zogenix, Encoded Therapeutics, and Stoke Therapeutics. We would also like to thank the American Epilepsy Society for their partnership with DSF to provide CME accreditation for this series. We will be sending emails following the session today with instructions for how to claim your credit. Lastly, registrants should have received a link to a survey to assess the baseline knowledge of Dravet syndrome among professionals prior to accessing this webinar series. If you intend to participate in future sessions in this series, which going forward will focus heavily on Dravet syndrome, please take a moment to complete this pre-series survey. Feel free today to drop questions into the chat at any time, or you can hold them to ask yourself over video or audio at the end of the talk. With that, I would like to introduce our speaker today, who is Dr. Scott Perry. He's the Medical Director of Neurology in the Genetic Epilepsy Clinic, as well as co-director of the Jane and John Justin Neurosciences Center at Cook Children's Medical Center in Fort Worth, Texas. He completed his medical degree at the University of Mississippi School of Medicine and completed general pediatrics and child neurology training at Emory University. He additionally completed a clinical neurophysiology fellowship at Miami Children's Hospital before he joined Cook Children's in 2009. His clinical and research interests include the use of epilepsy surgery for the treatment of intractable childhood epilepsy and the evaluation and treatment of genetic epilepsy syndromes. Today, Dr. Perry will be discussing telemedicine and considerations for the care of patients with epilepsy. Thank you, Dr. Perry.
All right, thanks a lot, Veronica. And thanks for everybody who had some time this Monday afternoon to join us for this first in the series. As she said, the majority of the talks in this series will concentrate around Dravet syndrome. Mine is much more broad and just kind of hits on telemedicine and how we can use it in epilepsy. Honestly, don't consider myself an expert in telemedicine by any means, but like the rest of you, I have had to become one over the last year. With its increasing use. So it'll be a fun topic to talk about and just things for everyone to consider. Excuse me. As far as disclosures, so we have them here. So I do work with multiple companies that work within the epilepsy and specifically Dravet syndrome area. None of that really pertinent to today's discussion, however. So today we're just going to talk about telemedicine, of course, and kind of define what it is based on law, really, and its use in epilepsy management. We'll discuss some of the barriers that have prevented widespread use of telemedicine in the past, some steps for a successful visit when you do have one on telemedicine, and also think about some of the future potential benefits of telemedicine and ways to advocate for change. So I put this kind of disclosure in the beginning that telemedicine is a constantly evolving service, as you'll see in the slides, and we talk about why it's evolving, mostly around law and payer regulations. So, things change every day. So I'll try my best in these slides to kind of paint the picture of where telemedicine is, understanding that every day there's slightly something different about the use of telemedicine in healthcare. So you'll hear different terms thrown around. Telemedicine and telehealth are technically two different terms. Telehealth is a term that is more broad and really encompasses telemedicine, which is an exchange of medical information using electronic communication between a provider and a patient, whereas telehealth often can apply to a variety of other services around healthcare, including things like, for instance, social work or other therapies. The technical definition of telehealth versus telemedicine is one defined by CMS, but each state may also have a slightly different definition of what the term means. Most of these slides, when I talk about specifics, I'll refer to what our law in Texas is. I'll tell you to always make sure you check your local law to see how it applies for you. But in Texas, telemedicine is indeed a medical service delivered by a healthcare professional, certified or otherwise entitled to practice medicine within the state and acting within their scope of health professional license, certification, and entitlement to provide a service to a patient who exists at a different physical location other than the health professional using telecommunications or information technology. So in short, you are providing services to somebody who is not in your office, basically. So if there was anything good about COVID, telemedicine probably is that thing. So thanks to COVID and the pandemic, we had an order from CMS at the direction of the president in March of 2020, which significantly increased the scope of telemedicine services in healthcare. It expanded telemedicine services under Medicare. It expanded where the service could be provided. It allowed audio via telephone only to be used as opposed to audio video. It expanded who could provide services via telehealth. It expanded what types of services could be provided, and importantly, waived HIPAA penalties. You'll maybe hear people refer to an 1135 waiver, and that was a waiver which basically changed the place at which services could be allowed. So under Medicare rule before, covered services could be provided, but had to be provided in originating sites, which were defined as kind of designated rural areas, places in which the patient would need to leave their home and go to this designated originating site, which was often a remote clinic or a hospital or some other kind of medical facility. The 1135 waiver changed that so that services did not necessarily have to be provided in those originating sites, but could be provided, for example, in the home, which has become incredibly convenient for patients, or maybe at a nursing home, for instance, for some of the elderly population, for example. So it changed the site at which that could happen. So as I said, a lot of different people could provide services under the relaxed rules, and that includes not just physicians, but nurse practitioners, physician assistants, midwives, clinical psychologists, social workers, dietitians, and other nutrition professionals. And it expanded the services that were allowed to be provided. So while we commonly will provide E&M visits or common office visits, you could also provide mental health counseling and preventive health screening. And as I said, the services now could be provided in a variety of locations, most importantly at home, but also through emergency departments or nursing facilities, etc. So as I said, the definitions of telemedicine will differ by state. So you'll want to refer to your own state law as to how telemedicine is defined when practicing it. But in Texas, basically, the state law says that it is a healthcare service delivered by a physician licensed in the state or a health professional acting under delegation and supervision of a physician licensed in the state, acting in the scope of their license to a patient at a different physical location than the physician or the health professional using telecommunications and information technology. So this was subsequently also amended around the pandemic, which allowed two things. One, allowed the visit to be initiated by the physician, basically meaning that you didn't have to have an established relationship yet with the patient to provide this kind of service. You could see new patients under the law, and also remove the explicit prohibition of telephone use, which was in the law before, that you could not have a telephone-only visit. So that was taken out at this time through the amendments. So, why is telemedicine important? I think we've all figured that out now over the years, or over the year, but there's, the variety of obvious reasons. One is because you can provide care when geography limits that access. For me, in a state like Texas, where some patients may travel 8 hours to get to our clinic for a 20-minute visit, to be able to carry that out over video, save them the trip and 16 hours of their life in a car, and provide essentially the exact same service is outstanding. Obviously, it's cost effective as a result of that. You save gas, you save lost wages from work. There's obviously a lot less time lost from work, lost time from school. Frankly, providers can save time as well. So I think from the provider standpoint, I find it clearly to be useful and more efficient, right? I don't have nearly the time wasted in the check-in process, the parking of the car, the coming up and asking you if you've been exposed to Ebola, just random things that just hold up the visit altogether. We don't have that to deal with. No-shows often go down as a result. It's just easier to connect. And so you can do those visits. And you could potentially save money. There's one study that suggested an average savings of near $30 per patient in just overall provision of care using telemedicine versus in-person visits. And I would suggest that the quality of care may actually improve over time. Obviously, if you're able to attend your appointments more often, that could certainly help with care. If it saves on time at all and prevents rushing, that's got to improve quality of care as well. So I think there's several instances where we may see some improvements. And when we talk about telemedicine and epilepsy, I think epilepsy really represents kind of an ideal service for telemedicine visits. And the reason for that is, number one, it's easier for the patients to attend the appointments. It's one thing if you're a kid and you got a mom and dad to bring you to an appointment, but even then they have to take off work, get you out of school and get you up there, and it's going to be a lot easier. But for adults with epilepsy, maybe they're not able to drive. Maybe they have to access public transportation to get to that visit. So the ability to do that from their home without having to go through that has got to be a significant improvement for them. Relieves a considerable amount of stress. You think about when you come to wherever your office is. I know when I come here every day. The parking lot's 7 stories tall with thousands of parking spots, and the building is gigantic. I know my way around this place, but if you're new to it, to come here is incredibly anxiety provoking, and even worse when you're sitting in the valet line behind another 100 cars that are trying to do the exact same thing, and you've got an appointment in 5 minutes. So a significant reduction of stress, easier for the patient. And the thing about epilepsy is that in general, most of the visit around epilepsy and the care of epilepsy is more about conversation and understanding the history and what's going on, more so than the examination itself. Not to say the examination is not important, but that's probably the least important part of the entire visit. So there are requirements for telemedicine that everyone should be aware of. Again, these next several slides they represent telemedicine rules in the state of Texas. You'll want to refer to your own state to make sure how your rules read, but they're probably quite similar. So first and foremost, telemedicine must provide the same standard of care as would be received in an in-person visit. So as I said, epilepsy fits this context quite well because you can really provide the same standard of care because the history is the important part, the physical exam less so. Counseling about the diagnosis and treatment can be conducted easily via telemedicine. There are some diagnoses that maybe don't work as well and that you have to see in person. Maybe not every time, but it may be more often than, say, epilepsy. One example I give is, if you in the neurology space are dealing with tone management, that's something where physically seeing the patient and touching the patient and understanding where the tone is important to treatment. So an in-person visit may play better for that kind of diagnosis than epilepsy. The physician must have a practitioner-patient relationship. As I said, that rule changed in Texas. So previously, this was telemedicine was more performed as a follow-up after we had established a patient practitioner visit through a new patient visit. Now a new patient visit can also be exercised through telemedicine as the initial visit. But the important part now of establishing a practitioner-patient relationship is, one, making sure you are indeed talking to the patient that you are supposed to be servicing with the visit. So you identify who the person is that you are seeing through telemedicine. You make sure you understand not only their identity, but where they are. Are they physically within the state or a state that you're licensed to practice? And that they are consenting to receive their services via telemedicine. After you've identified the patient, the rest of it is very similar to what you would otherwise do. You provide a history, a physical, you discuss their diagnosis, you plan follow-up care, and then each insurance and state, as I said, may have some different rules defining how that relationship is created. So you just want to make sure you fall within the rules. This next piece is really important. I think most people know this, but I think sometimes people make some mistakes around this, and that the provider providing the telehealth service must be licensed in the state where the care is provided and the site of care is the location of the patient. So that's very important. I get a lot of, I see a lot of patients from around the Southwest, but also from around the country. And obviously the pandemic has played some havoc in that care because I'm not licensed in every state in the United States. So I was, for example, taking care of several kids from the Northeast and from Florida. And when this hit, not being licensed in those states, unable to provide telemedicine services to them. So just important to know. I give an example. There's a lot of different things to think about, but say I'm here in Texas and I have a patient in Texas that I care for, but they are on vacation in Colorado and they have a medical issue for which they want to see me for. I cannot provide that care to them because they are currently residing in the state of Colorado. They are welcome to drive to the border and cross it and get into Texas and call me on their phone and we can connect via video, and that is just fine. And believe me, we have some patients that do that. They are maybe in Oklahoma and they will come just across the border and connect via telemedicine. We'll take care of the visit and then they'll go back to Oklahoma. But you do need to practice medicine in your own state. Importantly, many of the states exercised some emergency rules that really relaxed their licensing requirements. They either recognized other states' medical licensing, or they've made it significantly easier to get a license in their state during the pandemic. And that has been that's been great. But I will tell you, if you have done that and gotten limited licenses in other states, keep an eye on those states' regulations because they change frequently. Again, as an example, for those patients in Florida, I quickly worked to get myself a license in the state of Florida. And within about 5 to 7 days of making the application for the license, they changed their rules and decided they were no longer going to allow any more emergency license. And then other states where I actually was granted the license, they also changed their pandemic rules and decided they were no longer going to recognize outside providers. So you just have to keep an eye on that and make sure that if you think you're licensed, that you're indeed still licensed in those states. So next requirement is that you must maintain an adequate medical record. Okay, that's no different from any other care you provide, but just have a medical record of the encounter. What happened, it's just like a note you would otherwise do for a regular visit. You can certainly provide prescriptions for care through telehealth. Again, you just have to have that physician-patient relationship. There has to be on-call coverage for you, and you have to use appropriate technology to do that prescribing. Treatment of chronic pain has been an exception for some time. That was not allowed under telehealth and telemedicine rules, but during the pandemic, at least in the state of Texas, it was relaxed so that you could treat chronic pain virtually if needed. As I said, you must obtain consent for care and document that in the chart. Again, that's basically just identifying that the person you're talking to is in fact the person you're to have the visit with, and that they are consenting to provision of care via telemedicine. Care should be provided in a non-public facing platform, so obviously not in a public arena where anybody could join in and go to the visit. In the past, these methods needed to be HIPAA compliant. During the current 1135 waiver, you don't have to do that. That's why things like FaceTime visits and things like that were allowed. It was recognized that we needed to get telemedicine out to the masses very quickly, and waiting on everybody to be able to afford and to implement HIPAA compliant technology to do that was not going to happen quickly. So the HIPAA penalties were relaxed during this time period. So telemedicine, super easy, right? Get yourself a comfortable spot, get yourself a nice background, get yourself a good camera, and you have a visit. If you do a telehealth visit with a remote originating site, you might have somebody on the other end, like a nurse practitioner or a nurse or someone else to help perform portions of the examination, especially if there's certain things like, if you're looking in the ears or you want to use the remote stethoscope, you have somebody on the other end. Obviously, if you're doing the visit at the patient's house, you're going to be limited for those kinds of things. So what kind of barriers have been present in telemedicine over time? Technology has been a huge one, right? Technology in the past, as I said, needed to be HIPAA compliant with secure end-to-end communication. And these kinds of things would bring about considerable cost for any practice to implement. And frankly, the bigger the practice, probably the more difficult it becomes, not just from the machinery, but just from the overlying security of the system to protect health information. So that has been a huge barrier. Beyond just that, the facilities overall. So in the past, with the need for originating sites, it's one thing to have the equipment at your office, but then you also had to have a remote site where that in-person visit could take place. So that meant having another building, that meant having equipment at that building, that meant having staff to do pertinent portions of the exam, vitals, things like that. Now that's not as big of a problem currently, since you can do like video at home visits, but on the flip side, the patient may have the same problem as far as access to technology and facilities. So not every patient is going to have the internet communication necessary where they are to have a solid telemedicine visit. So it's still difficult for some people. As I said, state law, state and national law, frankly, have probably one of the biggest barriers and are still a barrier to some degree because it's so complicated to keep up with what the law is in each of the 50 states and whether or not you are abiding by it. But every state has their own individual health law related to the practice of medicine with the intent to protect their own citizens. So you just need to be aware of those wherever you choose to practice. Acceptance, of course, has been difficult. Doctors have been somewhat uncomfortable with the provision of telemedicine, because it's not how we practice. We always practice with seeing a patient in front of us that we can see, talk, and touch when they're there to do their exam, right? So the fact that we couldn't do that makes people a little bit uncomfortable, especially the examination part, kind of just understanding how you kind of create and complete the exam as best you can remotely. I think the conversation part too. So there's a lot of difficult conversations that we have, especially in neurology, and there's definitely some conversations that are more difficult than others to have via video, not in the same room as somebody, a little harder to read facial expressions and read their voice. And so there's some hesitancy to telemedicine as a result, but I think over time everybody's becoming more comfortable with that and able to do it much better. Obviously, patients also had some decreased acceptance. I mean, everybody on the surface thinks, man, it's a great idea not to waste a lot of time going to the doctor, but logging in, uncomfortable in the nature of technology, getting ready for the visit. Maybe having the visit in your home. There are different living conditions and concerns that people would have around doing visits from home. And there's a variety of reasons. Many people just felt comfortable, just like the doctor did, being in the same room talking to their doctor in a conversation. And of course, payment. Nothing occurs free in the world, especially not in healthcare. And payment has been a big concern because we want to make sure, from the doctor side of things, certainly want to make sure that we're getting appropriate payment for the services we provide. From the patient side, they want to make sure that the services they're getting are appropriately covered and the bill doesn't come back to them. So many state laws do require commercial insurances to cover telemedicine services. But I'll tell you, many of those laws don't stipulate what the rate should be. So just making a law that says you need to cover it is easy. An insurance company will be happy to say we cover it, but what they're going to pay for it is a completely different entity altogether. Many of the laws may not cover audio-only interactions. So while audio-only interactions may be allowed, the laws covering payment for that may not exist, and so they may not get paid for in some cases. And as I said before, Medicare in the past had a limited service availability using the originating sites. Fortunately, that is not a current issue. I put this link in here. I think it's a really good one for you to look at from AES, which covers a physician statement and a lot of common questions about telemedicine provision, not just in epilepsy, but telemedicine provisions in general. Of course, if this would only last forever, and we really don't know how it's going to live past the pandemic, what will happen. I can tell you that insurers have temporarily suspended and amended most of their rules related to payment during COVID so that visits you do by telemedicine are paid at the same rate as they would be in person. Many of the states, as I said, have relaxed their rules around telemedicine and licensing. However, you have to keep an eye out on not only state law, but on the individual payers that you work with, because they have been putting stop dates as to when they would stop allowing certain telemedicine codes to be used, or reimbursements to change, or when telephone only visits would no longer be reimbursed. And those dates change because there were definitely some dates placed out earlier this year, which have been changed when it was clear the pandemic was not going away. We get kind of these tables out frequently just to let us know the variety of different health plans available and what their current stop dates are, or their changes to their rules, so that we can try to keep up with as best as I can. But as I said, it continually changes. So it kind of wreaks havoc on the ability to schedule patients, because we often will schedule many patients with video visits and let them know that if the rules change prior to that video visit and their visit is no longer covered at a video as a video visit by the insurance company, we'll contact them to switch it to an in-person visit so that they won't be responsible for the cost. But that's really difficult to keep up with on a daily basis, to make sure you're looking at every single patient and where they're coming from and whether or not it's covered or not. Can definitely be quite difficult. As far as the codes you use for telemedicine visits, there's kind of three groups of codes, and this is explained pretty well in that AES document that I noted. The ones you'll be most familiar with are the ones that are listed under the telehealth video visit codes. Those are the same codes you would be using for in-person consultations and follow-up visits. The only difference is when you use them, you attach a modifier, a CPT modifier, a 95 or GT, depending on which one your payer is requiring. These visits are otherwise just like typical visits. They have the history, the physical, past medical, surgical, social history, all those kinds of things. All that documentation is there, review of systems, etc. You've indicated that you received consent to provide the service. Generally, we'll put a statement in there that the visit was conducted via video visit using video, audio communication, etc. Now, the virtual check-in column are some codes that are reimbursed by some insurance companies, but a lot of insurance companies don't reimburse those. Those are basically telephone conversation codes. So say a patient calls and wants to talk to you about a problem they have, and they're trying to determine, does it even require a visit? So you might talk to them for 5 to 10 minutes. You say, no, this doesn't really require a visit at all. You document the conversation, what the question was, how much time you spent. It's basically a very short telecommunication visit, and you can bill that. Now, if you talk to them on the telephone and then decide from that conversation they need an in-person visit, you cannot use the code to bill for that time on the telephone, because you will be actually seeing them in person and you'll bill for that visit. So anyway, as I said, these codes can be used. Most commercial insurance companies don't pay for them, but some do. And then finally, the last one is the e-visit. And e-visit is mainly electronic communication. So for those, for instance, that use Epic, that's like a MyChart communication from the patient. They send you in a question, you send them back an answer. So there are codes for the use of the electronic health record and secure emails. Again, similar to the virtual check-ins, they're not reliably covered by any insurance company. But there may be some that will. So I think there are some certainties and some unknowns to the future. Without doubt, we're going to see continued increased use of telemedicine. I think everyone's become comfortable with it. Frankly, it's an accepted, established way to provide care now. And so while there's always some concern that insurance companies may not cover telemedicine very well, I think the desire from the consumer, who is the patient, to have this service will drive the fact that insurance companies will continue to cover this in the future. It's just a matter of how well they're going to cover it. Whether at-home utilization will remain an option is unknown. I certainly hope it remains that way, because I think I personally can do just as good a job with a patient at their house as I can if they drive into one of our remote clinics. I mean, the only exception to that is if there are portions of the examination where we need somebody on the other end to kind of physically do that piece. But for a basic kind of conversation, counseling visit, I think that could be carried out at their home very easily. And as we've said, reimbursement is likely going to be some amount of barrier to full-scale implementation, and will vary by insurer most likely. So here, the following are just some tips for you to think about when preparing for visits. Again, I would imagine most of us have gotten pretty good at this over the last year, so you don't need these tips at this point because you probably have meetings all day long that are virtual. But that being said, location is super important, and how you do it is important. So using a device that has a good camera and a microphone, so generally an external camera and a microphone are superior to those built into most computers. If you have two screens, that's great, because you can put up, your note on one screen, the information you want to see right in front of you, and the video in front of you, so that you're making eye contact with the patient on the other end, just like you would if they were in the room. And obviously, as I show in this picture, you want to position the camera so that you show your entire face, not just the top of the head and the rest of your ceiling. You want to use a suitable location, and suitable locations are, first of all, private. This is a healthcare visit, so it does need to be private. It needs to be quiet. It'd be, great if, as much as we love our children, if we don't have our children running around in the background while we're trying to have a telemedicine visit. It needs to be a well-lit room, and you shouldn't sit in front of a window and in front of a light source, because it basically will turn you into a shadow. Quick tip that if you want to use green screen backgrounds, don't wear green, because you will disappear. So any portion of you which matches that color will often disappear into the background. And of course, using a wired internet connection, Ethernet or cable, is going to be much more reliable than using cell connection or Wi-Fi. And that's generally a problem on the other end more than it is with the healthcare provider, because a lot of patients will join via their cell phone or whatever. And I've had enough visits where I feel like I've missed the most important parts of the movie. I'm taking this exquisite history and I'm asking them to describe the seizure, and they are describing it what looks like in great detail, but the audio is just cutting out completely through it. So I have no idea what they said about the seizure as they're describing it. So you always want to make sure you have that good connection. Also important to think ahead of time if you need a translator for the visit. Most of the EHRs, if you do need a translator, you're able to actually connect to the translation service through the EHR, but you can also do it through a secondary external call, or of course you can still bring your live translator into your office with you to help with that. Now, your patients need to plan for the visit as well, and again, some may feel uncomfortable with the use of telemedicine. There's a great document that the Epilepsy Foundation has put together that I give you the link for here, for patients, just kind of walking them through what to expect in a telemedicine visit, how to prepare for it, and what to expect on the day that it occurs. It basically goes through these kinds of things, which of course you all know. You'll greet the patient online, you'll verify their identity, and then otherwise verify their location. As I said, important to make sure they are in a state and a location that you're licensed to practice in, and that you have consent for their treatment, and then otherwise you conduct the visit as you usually would. As far as the physical exam goes, you do all the physical exam that you can reasonably do remotely, and of course document portions of the examination you can't do. So, if you can't do a fundoscopic exam because you're doing an at-home visit, you just document not possible to complete the fundoscopic exam through remote video visit. You can review test results just as you would in the office. You can share your screen just like I'm sharing my screen with you today, and go over an MRI and show them what you're talking about, and then of course end with your follow-up recommendations and any counseling that's necessary. So next, what does the future hold? I think telemedicine actually offers the opportunity to offer services. So from the business side of medicine, offers opportunities for services that right now aren't really easy to offer, right? So some examples of that are same day or after hours visits, right? So as a neurologist, pretty busy. Usually the office is packed all day, but people no-show. and or cancel last minute. An ability to fill that appointment can sometimes be difficult, but at the same time, we get calls all the time about, can you work a patient in? And oftentimes we may oblige that, but saying I'll work somebody in means they still have to get from wherever they are to your office, park. There's a lot of time in there. Whereas with this approach, you can say, hey, yeah, I'd be happy to see them, and I've got time in 10 minutes. So let's send them the link, let's connect them, and let's do the visit. So you can fill those spots very quickly. I think there's also potential for after hours visits. I know as a parent, I offer appointments starting a little after 7 o'clock in the morning, and those are always appointments that are filled because people like to get it done before school starts, or they'd like to come after school. And so you can imagine this offers the opportunity for doctors to shift their schedule and maybe allow more early morning or after hours visits, because you no longer need my providing care between 5 and 7 o'clock at night is now dependent on me being willing to do it, not dependent necessarily on having the entire staff of the clinic here ready to check a patient in and get them ready into the room. So it really offers some opportunities to expand or shift your service. I think there could be some unique opportunities for multidisciplinary care. Many of you may participate in multidisciplinary clinics, and they're great for patients, incredibly inefficient for providers. Most multidisciplinary clinics have a lot of providers whose schedules just don't move smoothly because they're waiting on another provider to finish their piece of the visit. So I think the good thing about telemedicine is it offers the potential to have patients in a multidisciplinary clinic with just video and being able to get doctors popping in and out without all of us there waiting on the guy before it can be done. Hopefully telemedicine will open the option for people to get second or third opinions from distant locations. You get requests for patients who want for instance, because I do a lot of Dravet syndrome, I may get requests for a visit for Dravet syndrome, and to have that family trek all the way across the country for what is a 1 hour visit to then return to the airport to fly all the way back across the country for something we could have done via video, would be great. Obviously, that requires some changes of the ways we handle medical licensing in all of the different states, but I can certainly see that as a way for people to get some opinions that they want that they might not be able to get locally in a much easier way. And as I said, I think there's likely some cost savings to the use of telemedicine. Not only is there better compliance in general, which I hope translates to better healthcare overall and better outcomes, less emergency room use if we're able to do visits that prevent the need to use the emergency department or urgent cares. All those things will be helpful. On the last couple slides, I'll just look at some of there's a recent paper out kind of looking at the adoption of telemedicine over time. This was a cross-sectional survey over 35 different countries, 172 people responded. If you look at the top of the A column up there, that looked at the frequency of telemedicine use or remote use prior to the pandemic, and red is the never, which is a large proportion. It was up to 50, 62% of using either institutional, personal, remote systems. And then during the pandemic, you can see that section got much smaller. The overwhelming majority are now using it daily, if not weekly, and only a small proportion said they were never using any kind of remote approach. As far as other impacts and the way they're using remote services, remote clinics make up a huge proportion. Remote teaching in academic teaching institutions, and the remote meetings, of course, we're all incredibly used to now. So what can you do? Because I think it will take our input as well over time. You can definitely work with your state and federal representatives asking that they continue the push to expand telemedicine services. There are several acts out there to be considered by Congress for the use of telehealth that remove some of the restrictions and expand who can use it and how it can be done. Of course, stay informed, as I said, with your payers in particular to make sure how they are covering these services. Make sure their rules have not changed. As you know, they do like to change the rules and not necessarily let you know until they deny the coverage. So make sure you know that and continue to advocate with the payers. And this is for patients too. Patients need to advocate with the payers that these services need to be covered as part of their plans. So to conclude, telemedicine is here to stay, so get used to it and learn to love it. Epilepsy is an ideal diagnosis for the use of telemedicine. It won't replace all in-person contacts, but it certainly can replace an awful lot of them. And while there are a lot of barriers to full-scale, around-the-clock telemedicine implementation, significant progress has been made in just a very short time, pushed by the pandemic, and that's about the only good thing I can say about the pandemic. So that is what I have to say about telemedicine. I'm happy to try to answer questions and share what experiences I can. Thanks a lot.
Thank you so much, Dr. Perry. Yes, if anyone has a question, now would be a great time to pipe in. Give everybody just a second. I know I have a question or two for you, and I can go ahead and do that while we're waiting to see if anyone else does. So when you were mentioning that, you've encountered during some of these telehealth calls or telemedicine calls that, suddenly you have issues hearing the patient or the caregiver describing, what a seizure type has been like. How do you determine when a call is just not going to be successful? And do you try to just reschedule? Do you pivot to saying they need to come into the office next? How do you handle those?
So, so first of all, I've gotten really good at hand signals. Because a lot of patients will join in on the visit, and you see the little things at the bottom of the screen that tell you they're trying to connect to audio, but it's not happening.
Mm-hmm.
And so I use my hand signals to point to them where on the screen they can go find that. Very good at that. If we haven't established, we've established the visit, but it's clear, it just kind of keeps cutting out. And believe me, this has happened. This happened even at one of my own remote clinics, where you think the connection ought to have been the best, but it was not the best. And we were losing out. I have abandoned the video visit and just switched to telephone only, and just called them on the phone and said, listen, the connection's not working. Let's just try to finish the rest of this by telephone only, which is fine. You can do that. So that's a way to do it. And, I don't think I've had any cases where I've absolutely had to say, we can't. The only visits I've had where I said we just can't do and have to reschedule are ones where they just simply could not connect. We couldn't even get started to do it by video or by telephone. Those are usually people who are fairly remote, and cell service is just terrible. And so we basically, when we do get in contact with them, say we have to plan a better place for the next time we try to carry out this visit, so it'll be a little more reliable.
Makes sense. I think another question that I had, sort of thinking about advocacy for this to remain a viable option for patients and for providers, it seems like this state-by-state differences are an incredible hindrance to being able to do this effectively and efficiently. Is there hope that with advocacy that even outside of expanding access for the doctors to have to go be certified in every different state, do you think there's room for advocacy for not needing that, for them being a provider and certified in the state that the physician is in? Do you think that there's room in the future to sort of negotiate that being an option? I guess I'm thinking a lot from, a rare disease community like Dravet syndrome and these scenarios where patients live in Florida and want to see an expert across the country.
Yeah, well, there are already some push to do that. There are some states that have already kind of agreed and bound together and said licenses within this group of states go across state lines. It's just not every state, has joined that. Texas, likes to be its own independent country, has not yet, joined onto that kind of thing. So you're going to have some states that are going to hold out because they feel like their processes probably are, very important. They want to keep them the same. But there's already a decent number of states that are looking at that, and really I think that's the ultimate solution, is to have some kind of standards of medical licensing and then accepting them across state lines. As far as other advocacy, probably the highest yield advocacy that people can do is number one, keeping up with the Epilepsy Foundation has a good advocacy section to let you know what's going on at the federal level, because generally whatever the federal level happens with Center for Medicare Services, that usually will shape how other commercial insurers and states might act. So that's probably a great place to put the majority of your energy, is making sure from a federal level that these things remain very broad. And then locally, you can take it based on that approval.
All right, great. I guess if we do not have any additional questions, I think we can wrap up this meeting for today. And just thank you so much for taking the time to be here and speak with us all today, Dr. Perry. I know the Dravet Syndrome Foundation greatly appreciates all you do for this community, and really I see you as a real champion for the epilepsy community at large, and we appreciate all that you do.
Thank you. Appreciate you inviting me today.
All right. Thank you to all our attendees. Look for follow-up emails if you're interested in claiming this as CME credit, and I hope that you will join us for the next 6 sessions as this webinar series progresses throughout November. So thank you all.